Good day, everybody. Today, I would like to talk to you about the support to the HAT elimination agenda in the DRC, more specifically about the next steps to the interruption of Gambiense HAT transmission. You can see here the map of the DRC, and these highlighted areas are the areas where HAT is still endemic. The National Sleeping Control Program is financed through two big main donors through the ITM. You can see here the pink areas is funded by the Bill and Melinda Gates Foundation, while the rest of the country is covered by the Belgian cooperation funding. What we have seen over the past few years is that there is a steady decline of the number of cases, despite an increased screening efforts. Over the past 5 years, we were able to systematically screen more than 2 million people a year, even in COVID times. And despite all that, the number of newly reported cases is declining. So these low numbers have been reached through the classic control strategies, using mobile units and mini mobile units to do active screening and passive screening in fixed health structures. So we have historically low numbers, but they are spread over a large geographical area. And we can see that even the seropositivity of the screening tests is declining, meaning that the number of confirmation tests that need to be done is also declining, but these are technical skills that need to be maintained, and this is thus a challenge for the next step. So the question arises whether the current screening strategies are adapted to the context, because we need to maintain good coverage to avoid resurgence. We need to maintain expertise, as I said before, and we have to have a system for early notification of outbreaks. Many indicators show us that the number of cases are declining, the number of endemic villages and endemic health zones are declining. However, this is not the case in every area. As you can see here in the Kasai Occidental area, the number of newly reported cases has remained stable over the past few years. Moreover, there are still some gaps in epidemiological knowledge. There are blind spots because some of the areas are very hard to reach due to poor road infrastructures, but some are also non-accessible because of the insecurity. So there is a need for new tailored approaches. Here you can see the current control strategy for HAT case detection, meaning active screening, which is the larger focus by mobile units and mini mobile units, passive screening in fixed health structures, vector control, and treatment. However, since the number of cases is declining, then using mobile units is no longer cost effective. So the logical step would be to integrate disease control into the passive screening. However, there are huge challenges because of the low attendance rates of health structures by the Congolese population, and diagnostic expertise is hard to maintain because highly technical skills are required. So it would be of interest to continue to invest into classic active screening, however, to a lesser extent, and combine this with alternative strategies, such as reactive screening, screening in historic foci, and screening in blind spots. Vector control will still be a part of the control strategy. However, it will be also more tailored, most probably more targeted to the places where people get stung more, or the most endemic villages, for instance. And of course, treatment will still remain a part of the strategy. So talking about alternative active screening strategies, we will subdivide this into 3 types of foci: in active foci, historic foci, and in blind spots. Active foci will still remain in using a classic screening strategy, meaning mobile units or mini mobile units that will visit villages that have been reporting cases in the past 3 years or in the past 5 years. Reactive screening will be done in a village that is initially not planned. However, a new case is reported through passive screening. After verification that the place of probable infection is a village that is not planned to be visited, then these mobile units can be sent to these villages for a screening round. Screening in a historic foci implies villages that have not reported cases more than 5 years ago and where there was a screening round organized in the past 3 years to make sure that no new cases have arisen. Lastly, in the blind spots, exploratory screening we would like to organize exploratory screening, meaning these are villages that have not reported cases more than 5 years ago, and no new screening round was done also more than 5 years ago. So all of these strategies need to be accompanied by quality assurance to make sure that all of these diagnostic tests are being done correctly. And this can be done on 2 levels. First of all, you can do capturing images such as videos and photos using digital tools, such as in the example here below. And we would like to do blood sampling for all seropositive individuals, take these samples and send them to the regional laboratory for further serological and molecular biology testing. In the passive screening, the approach will be much more tailored according to the endemicity of the health zone. Meaning in health zones reporting more than 20 cases in the last 5 years, we would like to invest into a full package of classic screening and confirmation diagnostics in 1 hospital per health zones. In health zones where in the past 5 years have reported less than 20 cases, the first step would be screening using a rapid diagnostic test. If expertise and infrastructure for confirmation testing is available, then confirmation can be done on site. However, we will not invest to maintain this confirmation expertise. So we would like to invest into regional laboratories. This means that when a patient has a rapid diagnostic test that is positive, then additional blood samples will be collected to prepare a sample on DNA, RNA shield, and dried blood spots. These samples will be sent over to this regional laboratory for further testing, serological testing by ELISA or inhibition ELISA or trypanalysis, and further molecular biology testing to make sure that we are still detecting and treating HAT patients. So in conclusion, we are in a transition phase and we are preparing to transition from a screen, confirmation, treat strategy to go to a screen and treat strategy, meaning a single dose HAT treatment when a screening test is positive. However, we are not there yet. And during this transition phase, we would like to prepare ourselves and we would like to have a much better and much detailed overview of the HAT epidemiology in the DRC. Thank you very much for your attention and have a good day.